Good afternoon, everyone, and welcome to today's webinar hosted by Better Medicare Alliance. As each of you know, healthcare policy remains front and center, sometimes always, but particularly during the ongoing COVID-19 pandemic. What you may not know is that 26 million American seniors and those with disabilities are entrusting their care and coverage today to Medicare Advantage, and they're your constituents. Medicare Advantage now exceeds 40% of all Medicare enrollment, with over 50% enrollment in more than 60 congressional districts across the country. Medicare Advantage beneficiaries are proportionally more diverse, lower income, and have more social risk factors than beneficiaries in traditional Medicare. Today, just a few examples of what I mean by this. Today, more than 31% of Medicare Advantage beneficiaries are racial minorities, as compared to just over 20% in traditional Medicare. And half of Medicare Advantage beneficiaries live on annual incomes of less than $24,500 a year. 20% are dually eligible for Medicare and Medicaid. Another 20% are retirees and employer-sponsored MA plans. You'll hear more about those during the panel discussion. When we speak about Medicare Advantage, but it's important to understand that while everyone can choose MA, and they do, it is the healthcare coverage choice of a growing number of vulnerable seniors with chronic conditions, high needs, social risk factors, and those under 65 with disabilities who are eligible for Medicare. Even with a population as complex as I just described and who have complex medical needs, Medicare Advantage delivers consistently better outcomes for beneficiaries. Lower avoidable hospitalizations, more outpatient visits, and an average savings of $1,600 per person per year over traditional Medicare. Right now, as COVID-19 persists, over a year into this pandemic, Medicare Advantage plans and providers are responding to this crisis, waiving consumer costs, expanding access to telehealth, checking in on vulnerable beneficiaries, and leveraging supplemental benefits to keep consumers safe and healthy at home. That's why consumer satisfaction with Medicare Advantage just reached an all-time high of 98%. Even in the middle of a pandemic. Why is this important to you? First of all, because MA beneficiaries are in your districts and policies members vote on may well impact the coverage and care they depend on. And second, because Medicare Advantage is leading the way in modernizing Medicare by transforming the financing and delivery of care that is improving coverage and cost in Medicare. Better coverage at better cost is something we want you to know about. So with those reasons, we are going to take a bit of a dive into how Medicare Advantage works. BMA's Policy Director, Deborah Estes, will provide an overview of Medicare Advantage and the framework that enables this transformation. Then I will moderate a panel with three outstanding experts who will share the remarkable work that they do and the role that Medicare Advantage plays in their organization's successes. All three represent Better Medicare Alliance ally organizations and are active in advocacy for Medicare Advantage. I'll introduce them now, but you'll hear from them after the presentation by Deborah Estes. First, we'll hear from Jane Gilbert, who's a CPA, and she's Director of Retiree Healthcare for the Teachers Retirement System of the state of Kentucky. Jane has been serving retired Kentucky teachers since 2002. She manages 2 retiree health plans covering 48,000 retirees and will speak to the role that Medicare Advantage plays in providing health and financial security to these retirees and to the retirement system as a whole, as well as speaking more broadly for the value of MA for the over 2 million teachers, public employees at the state and local level, and union retirees across the country. We will also then hear from Dr. Rushika Fernandopulle, who is a co-founder and CEO of Iora Health. Dr. Fernandopulle is a Harvard-trained physician who co-founded Iora Health to reimagine primary care, placing an emphasis on a strong doctor-patient relationship and improving health outcomes at lower costs for their patients. Today, Iora has practices around the country, providing primary care and care management services to seniors. He'll share how the framework of Medicare Advantage is important to his patients and to Iora's success. He is known as one of the leading innovators in moving healthcare delivery to meet patient needs, and will tell us what MA means to doctors and patients, and how he might even say it's only the beginning of all that we can do. And last, we will hear from Lucy Theilheimer, the Chief Strategy and Impact Officer for Meals on Wheels America. Meals on Wheels America is a leadership organization supporting more than 5,000 community-based programs across the country that are dedicated to addressing not only hunger, but senior isolation. Lucy has been with the organization since 2016 after serving in multiple roles at AARP. She has a master's degree in healthcare administration from George Washington University. So just a couple of final notes. We'll also be allowing for time to answer your questions at the end of our presentation and discussion. If you have a question at any point, you can ask it using the Q&A function in Zoom, and then we'll compile them all and ask them after the presentations. Finally, I want to let you know that we've summarized much of the information that you will hear today in a short, easy to read policymakers guide with links to our reports and fact sheets that are particularly timely with more information on a lot of the subjects. And we've created this just for your offices. We'll be sending you the document over right after today's event. We hope at BMA that this will be a useful resource for staff on the Hill throughout the year. And of course, we're always available for one-on-one calls or emails, or even, I guess, virtual visits if you have more questions that we haven't answered today, or more things that come up around Medicare Advantage later in the months ahead. Please be in touch. With that, I'll turn it over to Better Medicare Alliance's Policy Director, Deborah Estes, to continue our program.
Thank you, Congresswoman. So what we're going to go through today is Medicare Advantage 101, and we're just going to pull up our slide deck here. Hopefully everybody can see it. So let's start by discussing what is Medicare Advantage. Next slide. So at its most basic level, Medicare Advantage is one of two primary ways that a beneficiary can receive Medicare. The first option is through traditional fee-for-service Medicare, which is also sometimes referred to as original Medicare, or through Medicare Advantage. The most fundamental difference between the two is that in traditional fee-for-service Medicare, the government administers the benefit, whereas in Medicare Advantage, a health insurance organization administers the benefit. Health plans that offer Medicare benefits follow stringent rules to ensure that there's proper access and quality of care. For example, they have to offer all of the same benefits that are covered in original Medicare, but they're also able to offer additional benefits that aren't covered by original Medicare, which we'll discuss in today's presentation. Some of the other key differences between the two are that Medicare Advantage generally has, those health plans generally have provider networks, and provider networks are an important part of the offering in that they help for integrated healthcare, especially between all the different providers and the insurance carrier itself. And they're very commonplace today. We see them a lot of times in commercial or group health insurance plans as well. Medicare Advantage may and often does have different cost sharing than original Medicare. It also has a maximum out-of-pocket limit, which does not exist in traditional fee-for-service. And then, as I mentioned again, there's also the opportunity to offer additional supplemental benefits that aren't provided in traditional Medicare. So on the next slide, what we're going to see here is this chart, which shows how Medicare Advantage fits within Medicare in general. So original Medicare has multiple parts. For example, we have Part A, which is how beneficiaries receive hospital insurance. And this covers not only hospital stays, but it can also cover nursing facility stays and things of that nature. Sometimes there is a premium, but not always, and there's usually a deductible, and there are different copays and co-insurances depending on the service received. Then we have Part B, which is how original Medicare covers outpatient services, such as doctor's visits, lab tests, x-rays, things of that nature, and physician-administered drugs. There is a premium for Medicare Part B, and there's also a deductible. Co-insurance generally is around 20% for these services, depending on what the service is. And then what we also see is Medicare Part D, which is the prescription drug benefit under Medicare. Similarly, there is a premium generally speaking, there is a premium for Medicare Part D. This year, it is a little bit less than $31 per month. the Medicare Part D benefit has multiple components, but generally speaking, there's a deductible, and then the beneficiary spends until a certain point when they hit their catastrophic limit with the donut hole in between. We're not really going to get too far into Medicare Part D today, but if you have any questions, we have some great resources on our website. Then we have Medicare Advantage, which is sometimes referred to as Medicare Part C. This is sort of like a one-stop shop for all the other parts. As I mentioned, Medicare Part C or Medicare Advantage has to cover everything that's covered by Parts A and B, and most Medicare Advantage plans also cover prescription drugs. One of the things that works well for beneficiaries here is that there's usually only one premium in Medicare Part C, rather than having to pay multiple premiums in through A, B, and D. There are also some plans that have $0 premiums, and we'll talk about that in a little while as to how that's possible. So now we're going to go on to the next slide and talk about the different types of plans that are available in Medicare Advantage. So the first one that we see here are individual plans. These are plans that beneficiaries can go out and choose on their own, either through the Medicare Plan Finder tool or through conversations with SHIP counselors or agents and brokers. Then we have employer plans. These are plans that employers offer to their retirees. And then there's also SNP plans. These are special needs plans that target a specific set of beneficiaries, whether those who are full dual eligible or partial dual eligible, meaning that they have both Medicare and Medicaid. There are also those SNP plans for those who are institutionalized and those who have certain chronic conditions. Next slide. So let's talk about the consumer protections that are available in Medicare Advantage. As I mentioned before, there's an annual out-of-pocket maximum in Medicare Advantage that doesn't occur in fee-for-service. In 2021, this annual out-of-pocket limit is $7,550, but some plans have lower limits than that. Also, as I mentioned, there's a Medicare Plan Finder tool, which beneficiaries can use to locate a plan. On this tool, there's information around quality metrics, referred to as star ratings, which can help inform their decision-making when picking a plan. And we'll talk about star ratings and quality in a little while. There's also this flexible benefit and payment structures in Medicare Advantage, which is what enables plans to provide supplemental benefits. And also there allows Medicare Advantage plans to have high value provider networks because payment is a capitated prospective system. And so it enables health plans to partner with healthcare providers who also value providing high quality care to beneficiaries. Next slide, please. So one of the things that we want to sort of talk about here is who enrolls in Medicare Advantage. So on the next slide, so what we see here is that beneficiaries are increasingly turning age 65 and aging into Medicare. We know that about 10,000 beneficiaries a day turn 65. And so what we see is that enrollment continues to grow. And by around 2030, Medicare Advantage will actually account for at least 50% of all Medicare enrollment. Next slide, please. So this slide is showing you the concentration of plans. As you can see, Medicare Advantage plans are offered all over the country. What we have is that the trend tends to be that mostly the highest concentrated areas tend to be in urban areas, and then states such as Florida, Southern California, and New England. There tend to be some fewer options available in rural areas. And then what we see is in Alaska is actually the only state that doesn't have any Medicare Advantage offerings. However, more than 99% of beneficiaries have access to at least one Medicare Advantage plan. Next slide. So similar to what we looked at on the previous slide, what we're seeing here is beneficiaries who have access to a $0 premium plan. And so what that means is that they don't actually have to pay for the plan. Again, they're widely available across the United States in similar regions where we see really high penetration, such as Florida, Southern California, and parts of New England. And so as we get into payment, we'll talk about how all of this is possible. So next slide, please. So now we're going to talk about payment. So what here, this is a little bit of a busy chart and a busy slide, but it'll all make sense in a few minutes. So CMS pays Medicare Advantage plans a set amount, and this amount is per beneficiary per year. And so what CMS does is they establish a payment rate using the following process. They calculate a benchmark for each county in the United States, And this benchmark is basically an average of what fee-for-service spends on each beneficiary in the county. And then plans submit a bid, which is their estimate of what it will cost them to provide care and coverage for each beneficiary enrolled in their plan. And then this bid is then compared to the average benchmark, the county level benchmark, and that's how payment is determined. So here what we see on this slide is an illustration of two specific scenarios. The first one on the left is when a plan bids above the benchmark. So when a plan is bidding above the benchmark, the difference between the bid and the benchmark actually gets paid by the enrollee in the form of a premium. On the right, what we see is when a plan bids below the benchmark. And so when a plan bids below the benchmark, the difference, which is known as the rebate, now this is different than rebates in Part D, is part of it is retained by the plan and part of it goes to CMS. And the rebate dollars that are retained by the plan can be used for certain purposes, such as lowering beneficiary cost sharing or premiums, which is how we get $0 premium plans, and offering supplemental benefits, such as dental, or vision, or coverage for hearing aids, things of that nature. So what we can see here is that the payment structure strongly encourages plans to bid below the benchmark so that they have more rebate dollars available to them to provide these value-added services and lower beneficiary costs and out-of-pocket costs and premiums. So this is a very simplified example, but it's just wanted to sort of level set how payment works in Medicare Advantage. It is important to note that there are a variety of factors that impact payment to Medicare Advantage, including things such as risk adjustment, which increase or decrease payment. And this is based off of the health status of each beneficiary, of each enrollee. And so this is important because it removes incentives to avoid high need, high cost beneficiaries. Additionally, plans that receive higher quality scores are able to retain a higher portion of the quality bonus payment and the rebate that they receive. So this also creates a financial incentive for plans to really focus again on quality and providing high quality, high value care to beneficiaries. Just a quick note on the bid process itself, plans spend a lot of time calculating and preparing for this, and they're always due the first Monday of June before the following year. So for example, this year on June 7th, plans will be submitting their bid for calendar year 2022. On the next slide, please. So one of the things that we hear is that policymakers often ask what the government is paying to Medicare Advantage plans and whether or not that's more or less than fee-for-service. And so what we're seeing in this slide is that payment to Medicare Advantage has consistently decreased year over year since 2009. And it's important to note that this payment, which is almost equal to fee-for-service, accounts for Medicare Advantage plans' ability to provide additional benefits, coordinate care, offer care management, and hitting this 101% takes into consideration the quality bonus payments that plans also receive. Next slide, please. So we've mentioned supplemental benefits a few times, so let's talk about what they are. So supplemental benefits are benefits that are additional to what is offered in original Medicare, and they have to meet these three criteria together. So it has to be a benefit that a plan incurs a cost for a service that is primarily health related and the service is not covered under original Medicare. So when we think about these types of supplemental benefits, we think about things such as dental, vision, hearing, and fitness benefits. In 2021, 87% of health plans or Medicare Advantage plans offered a dental benefit, 93% offered a hearing benefit, 96% offered a vision benefit. And in fact, 80% of all Medicare Advantage plans offered some combination of dental, vision, hearing, and fitness, and over 50% of plans offered all four. Next slide, please. So there's another type of supplemental benefits that you'll also hear referred to. These are known as the special supplemental benefits for chronically ill. And as part of the Bipartisan Budget Act, or the BBA of 2018, this included the Chronic Care Act. And what this act did was a lot of things, but it actually changed the statutory language around supplemental benefits, which effectively created this new category of benefits, as I mentioned, known as SSBCI. And so this law actually opened the door so that for the first time, as plans are actually allowed to cover benefits to help deal with social risk factors and to address social determinants of health. So this allows for things such as meal delivery, non-medical transportation, and food and produce prescriptions. It actually also allows health plans to to install temporary modifications, safety modifications to seniors' homes. However, it is important to note that there are limitations. For example, anything that is installed in a beneficiary's home has to be temporary, and it cannot increase the value of the home. Next slide, please. So in 2021, supplemental benefit offerings grew in 88% of the supplemental benefit types that are being offered. So what this means is that we see an expanded and more plans offering these benefits. So the top 5 SSBCI benefits in 2021 are food and produce, meal delivery, social needs benefits, pest control, and transportation for non-medical needs. Almost 2 million beneficiaries have access to a Medicare Advantage plan that offers a food and produce benefit, and over 1.5 million beneficiaries have access to a plan that provides them meals. I encourage you to look at our website. We actually just released a brief with the actuarial firm Milliman that goes a little bit deeper into the supplemental benefit offerings for 2021. Next slide, please. So quality measurement and oversight in Medicare Advantage are both very important to the services that are offered in Medicare Advantage. Next slide. So the quality measurement system in Medicare Advantage is known as the star rating system. And within this system, health plans are measured on the health outcomes of their beneficiaries and the clinical performance of the overall health plan itself. There's a 5-star rating system, and it goes from 1 to 5 stars, with 1 being the lowest and 5 being the overall highest score that a plan can receive. And plans are rated on 47 individual measures. Next slide, please. So what this is showing here that we see is the importance of the quality measurement system or the star rating system and how important of a tool it is in Medicare Advantage. Not only does it help beneficiaries pick a health plan, it also provides incentives to health plans by using the quality bonus payment system. What this does is it incentivizes ensuring that beneficiaries continue to receive high quality care. We know that any health plan that is low rated, not only can they not enroll beneficiaries through the Medicare Plan Finder tool, additionally, if the plan is low rated for consecutive years, which it would mean that they have a lower than a 3-star rating for multiple years in a row, the contract is actually terminated. And next, what we'll talk about is the importance that quality measures play in driving better outcomes. Next slide, please. So what we see here is how Medicare Advantage can and does achieve better outcomes, especially in those when looking at original Medicare. So in a recent study that we put out in December, we actually found that Medicare Advantage did better than original Medicare on 17 of 22 clinical quality metrics that were evaluated. So this included things such as rates of pneumonia vaccines that were 50 to 52% higher, rates of eye exams for diabetics that were 14 to 56% higher, and rates of depression screenings that were 18 to 27% higher in Medicare Advantage over fee-for-service. The study that we did also found that there were lower rates of avoidable acute hospitalizations for high-need, high-cost beneficiaries. For example, we found that there was a 57% lower rate for beneficiaries who had major complex chronic conditions and a 45% lower rate for beneficiaries who were considered to be frail elderly. We also found that Medicare Advantage had higher costs for outpatient services and tests in the primary care setting than in fee-for-service Medicare. I encourage you to look at the fact sheets and the report on our website, which have a lot of really good, helpful information that goes a little bit deeper into how Medicare Advantage provides better clinical outcomes and quality than fee-for-service. Next slide, please. So as I mentioned, there are checks and balances in place to ensure that Medicare Advantage continues to provide the highest quality of care for beneficiaries. So a few examples of this include the provider network and network adequacy standards. This is ensuring that beneficiaries continue to have access to any and all types of specialist and provider and facility that they would need to access and that they would have access to in original Medicare. The bid review process also enables CMS to review the benefits and the cost sharing that a plan is proposing to put out and ensure that beneficiaries have access to what they need. And then there's also the appeals and grievances process, which contributes to the quality score that health plans receive. Next slide. So be sure to stay in touch with us and check out our website for additional resources. And now I'll turn it back over to you, Congresswoman Schwartz.
myself. Let's see. Sorry. Should have been prepared. Excellent. Okay, we're back. We're back on. I would ask our panelists to join me as well, so we can begin this panel. So, Dr. Fernandopulle would be great, and Lucy, I don't see you. I guess, are you all on?
Yes.
Okay, great. Good. All right. Well, I think what I want to do to get started with this conversation, you've I've given out a lot of information about how MA works. So let me start with you, Rushika, if I might, in just asking, what does all this mean when you're actually putting together the primary care groups that you do, and how does Medicare Advantage really lend itself or really enable you to do the kinds of things that you hope to do and do in establishing primary care groups and care management, and what does it mean, and how that's really enabled you to do what you do. Tell us a little bit about that. And if you could also tell us a little bit about how that applied particularly during the COVID-19 crisis.
Great. No, thank you very much, Congressman Schwartz, and it's good to be here. So Iora is a de novo primary care group. I'm a primary care doc. I started this about 10 years ago to say that we need a different way of delivering healthcare in this country, particularly for seniors. You know, our current model of care, despite largely good intentions and spending an obscene amount of money on it, is fundamentally flawed, right? Because it's about transactions, document, code, bill, next. What the system does is encourage people to do more things to people as opposed to actually make people healthier. And in the end, that's what we want for ourselves, for our mothers, for the system, is to actually improve health. We built a new primary care model, which is really built around relationships and not around transactions. And Medicare Advantage is the fuel that lets us work. So in the typical Medicare system, for the 2/3 of the people not in MA, the only way we can get paid as a doctor group is fee for service, where we submit a bill for each thing we do and we get paid. There's an inordinate amount of coding sort of junk that we have to go through, and it just simply encourages transactional medicine and doesn't get us where we do. In Medicare Advantage, we have the flexibility to contract with MA plans, people like Humana and Blue Cross of North Carolina and United, and that allows us to get paid a different way, what's called value-based payment, where we get paid not to do more things to people, but actually make them healthier. And that's fundamentally different. So we think our job as primary care is not see one patient at a time, do the best job I can, but we have a population of people. They're our responsibility, and our job is to improve their health, keep them out of trouble, and do whatever it takes. Fundamentally different. And so it allows us to do all sorts of really cool things. So all of our business is in Medicare Advantage because we can't really work with regular Medicare. It allows us to provide MA patients with this completely different model of care, which includes very robust teams, personal health coaches, allows us to email and text and do video chat with them, allows us to be proactive, reach out to them, let their daughter Skype in for the visit, allows us to have to see their whole medical record. You talk about transportation, we can arrange transport through Uber and Lyft to try and pick them up. We can help them do things in their houses. Really, the flexibility to actually improve health is what we do. So this came in really handy in COVID-19. So like everyone else in the rest of the country, in the middle of March, we realized there was this deadly virus spreading and we had to react quickly. So over a weekend, we transformed all of our care. We said we were essential for our patients. We kept all our practices open, which many practices were not able to do. We said if we can, literally overnight, we shifted 92% of our encounters to telehealth, video or phone. And we said, if we need to see you in person, we're here. But if we can safely do it by video or phone, let's do that. We figured out lots of ways to sort of help seniors with video who had trouble with that, because that was important. Happy to talk more about that if you want. And the other thing we did is over the first 2 weeks is we reached out to every one of our patients. We reached over 90% in 2 weeks and said, look, I know you're scared. We are here for you. We're open 24/7. By the way, you might hear from people that you should go out to the tattoo parlor or the beach. They don't mean you. You're old and sick. Right, you need to stay home. Do you have enough food? Do you have enough medicine? How can we be of help? And this really works. Even today, by the way, we're doing over 50% of our encounters by video, right?
Wow.
It's exactly the right thing to do for people, right? And huge impact, right? Only 11% of patients in the first 3 months of the pandemic heard one word from their primary care doc, right? Because they were struggling with their income. And what's great is because of Medicare Advantage, we didn't have to worry one iota about that. We get paid per patient. We could do the right thing. We had all the technology and the teams and the process to do this. So I think what, COVID has shown, if it didn't before, that these sorts of value-based primary care models are exactly what we need to actually improve health, which is what we do. So by the way, our COVID hospitalization rate and our COVID infection rate was half of what it was for seniors in the rest of the country. So this stuff actually matters to improve outcomes.
Yeah. Well, thank you for sharing that. And that was a lot in a small amount. I have to say we did once I have a chance to observe a conversation with one of your coaches and his patient, and it was just charming. It was just wonderful. They really had such a relationship, and she talked about her depression after her husband died, and her cancer, and her not being sure about going into MA, and how it all worked out so well. It was really quite a lovely conversation, but they had a quite cute interaction, as a matter of fact, which was great. But I know we also heard from others that during COVID, MA providers who were working under MA, because they had a list of patients they knew was at risk, they had teams and care managements who could really reach out to people. And of course, we did some polling during that time, which was just extraordinary, the response that the beneficiaries had about how important that was to them. And we do know that social isolation is something that you probably knew about and others knew about, but the tools to actually address that issue. So it was not only the clinical care, but it was the fact that you reached out and you created that touch point for people, created a sense of security that they didn't necessarily have at a very troubling time. And well, we will talk more about this later, but certainly telehealth is not going away. MA's been a leader on it, but maybe just one more word about just that. We've heard from a lot of other providers and who really want to keep this going, just because it is convenient, even though there are barriers. And maybe you want to just mention that, if you could, about the barriers that people had in use of telehealth might be useful for people to hear too.
Sure. So I think there are several. So one is what I would put in the category of stupid regulatory requirements, where we have the state-based regulations. So we have a practice in Hanover, New Hampshire, and literally it's right on the river. It's on the Connecticut River. Literally, you could throw a rock and throw it into Vermont from New Hampshire. And yet, if a patient's sitting in their home in Vermont, it used to be we couldn't do telemedicine to them because it's a different state, which is just completely asinine, right? It's completely asinine. And thankfully, during the pandemic, those rules have been suspended. And I really hope, by the way, that we keep them suspended, because we've shown that nothing bad happens, and these were just stupid rules. I think there were payment issues where, during fee-for-service, you would sometimes not pay for telemedicine or pay at a different rate. Then the good news about being in Medicare Advantage, and because we're in these global payment models, we don't care, right? So that was not a barrier. So the barrier we did face was about simply the seniors, and we take care of old, vulnerable, poor, largely minority seniors, may have trouble with the technology on their end, not on our end. And really about 40% of our seniors had some barrier. And it was one of three things. It was almost evenly split. It was either not having bandwidth, and it's actually surprising, and maybe a different issue that your congressional folks could work on is getting actually broadband to more parts of the country. It's like shocking in 2021. Number two is people just didn't have the right devices, which had video capabilities. And third is cognitive problems, right? Dementia, et cetera, which we're not going to fix. So we were able to be really creative in actually getting tablets and mailing it to people's houses. We had a program where we had our health coaches actually drive and deliver a tablet to people so they could use and they'd gather it back up. And I think, again, the word is flexibility, that if you think about an original Medicare, there are very rigid payment rules. I get why that's true. And the only way to change those payment rules is through an act of Congress. And again, no offense to the people on this call, but nothing happens in Congress. And so, of course, whereas what we can do in Medicare Advantage, we have flexibility to do what the right thing for the patient is. And that means delivering a tablet to their house. It's our decision. We have to decide, is it worth us? And for me, it's if I can avoid a $1,000 ER visit, delivering a $100 tablet to their house is a no-brainer, right? So the flexibility that we have through Medicare Advantage to do the right thing for patients based on our judgment, because we actually know the patient, is what allows us to do these things.
That's great. Well, and just to understand, again, back to what Deborah presented, is that the fact that plans get paid per person per month to take care of all of the hospital and medical benefits that are under traditional Medicare, but have the flexibility if they do bid below the fee-for-service benchmark, they can use some of those savings, and they have to use them actually directly for beneficiaries. And that's how you have the flexibility, provide more visits, do what they have to do, but it's not with extra money, it's actually for repurposing that money in a way that we hope gets people to primary care, keeps them out of the hospital, and we do know that it's showing that. So it's really great.
Yeah, I mean, so the real secret is, we are spending money so inefficiently in the US, right? But by underinvesting in primary care and the things I mentioned, we end up spending on people getting complications go to the hospital. So people like us, and there are many, not many, there are a growing number of folks like us, show that we overinvest in the primary care and the prevention and these sorts of social interventions. And we have huge drops in 40% drop in hospitalizations, 50% drop in ER visits, 20% drop in total spending, 20. That's a huge number, right? The only way Medicare will bankrupt us if we don't do something about it. And keeping in fee-for-service is a recipe for bankrupting the system. I think if we allow people like us to actually improve people's health, that's the only way we're going to save money in Medicare.
Well, let me move on. We may come back around. I hope we get to questions so we can all talk together. But let me move on, just because we have been talking about social isolation and these supplemental benefits and these other things you can do. Some of those are done by the medical providers themselves. Some of them they've done in cooperation with and through payment to other providers. You talked about using Lyft or Uber for transportation. But one of the other areas that has actually become keenly of interest and understanding is the issue of nutrition and food. So Lucy, I wanted to bring you into this conversation. And we just came out with the new numbers from Milliman that show that 57% of Medicare Advantage plans provide some form of supplemental meal benefit, and 31% of plans provide these meals on a more permanent basis, specifically for people with chronic illnesses. So tell us more about, I know that Meals on Wheels really stepped up in an enormous way, and there's some extra funding directly to Meals on Wheels to address nutritional needs of seniors and the issue of sort of companionship. Can you tell us a little bit more about Meals on Wheels and your relationship with Medicare Advantage plans and providers, and how that has helped to move this discussion about the importance of food and nutrition, particularly for frail seniors, particularly those who have many chronic conditions. Tell us how that's all fit in for you. Yep. Do we have Lucy? Oh,
I'm sorry. Thank you.
Okay, Rushika was saying I have to answer this question too. No,
you're on Zoom, and I'm still doing that sometimes.
I know. Go for it.
Sorry about that. Thank you for having me here today. So yes, Meals on Wheels America has been working with Medicare Advantage plans across the country to really look at ways and opportunities that we can leverage the full benefit of the Meals on Wheels service, which we refer to as the More Than a Meal service. So we know that nutrition is, one of the essential building blocks of life, right? And that access to good nutrition is what's going to help people optimize their physical and mental well-being. It will help them reduce risk of chronic disease. There are ways that there are to manage chronic diseases if they have them, if they're diet related, like diabetes or cardiovascular, keeps them stronger. So you avoid things like fall risks and all of these kinds of things. So bottom line is, nutrition is good for the seniors and it's good for healthcare system because it keeps people out of high costs. But nutrition is just a piece of the picture, as you point out, is that we know that particularly high-risk, vulnerable seniors are faced with a multitude of challenges, from food insecurity and having access to good nutrition to being isolated and alone. We know that the Meals on Wheels clients are disproportionately low income. They disproportionately live alone. They're disproportionately people of color. They have more chronic conditions. They're taking multiple medications. So it's a high-risk population. So the opportunity with Medicare Advantage is to be able to extend the reach and impact for a broader range of services. So Medicare Advantage can offer nutrition benefits, but they can also offer some of those other, particularly under SSBCI now, some of those non-health related wraparound services that are so essential to keeping people healthy and keeping them independent in their homes. And so that's what we strive to do. Meals on Wheels brings the opportunity to, they're on the ground, they're in the community, They're touching people one way or another, even through COVID, on a very regular daily basis. They know what's going on in the home. They can address safety hazards. They're keeping their eyes and ears on them over time and making sure that if there's anything that's changing, that needs get addressed over time. They connect them to other community services. There is no other provider that can offer that range of services to a Medicare Advantage plan. So that's what we try to stress, and that's what we try to make available to more and more seniors via Medicare Advantage, to the extent that we can make that happen.
It sounds great. And we know how essential it is. I want to just thank you too, for I know all the meals that got delivered and how you had to step up during COVID as well, both for Medicare Advantage beneficiaries, but for others as well, because of the intensity of the needs and isolation, and people were trying to stay away from each other. So even family members like, what do I do here? So and you work with volunteers. So I know that they also probably, some of them are probably themselves. And so just quickly, because I do want to go on to Jane, I just want to say anything more you want to say about the things that were brought to light during COVID-19.
Sure. I mean, COVID absolutely shed a light on social isolation in a new and different way. And Meals on Wheels programs did everything they could to continue to engage with their clients. So many programs engaged in contactless delivery. So they knocked on the door, they didn't go in the home, but they stepped back, waited for someone to come to the door, and then had chats with them and made sure that they were okay. They started up telephone check-in programs. They recruited volunteers from all different, younger folks, corporations stepped up to offer volunteers. So programs continue to do everything and anything possible to maintain a regular contact with their clients and make sure that they had everything they needed. And in some of them were extremely innovative, and they started tech-based programs, and they too provided tablets or telephone-friendly visiting, all different ways that they could engage with individuals to address isolation. But I will say that while things are getting better, programs are not seeing any light at the end of the tunnel. They see the need continuing to persist. They don't expect the need or the demand to go back to pre-COVID levels. It's not clear. We've been doing research with older adults. It's not at all clear when seniors are going to feel comfortable and safe to come back out, when congregate sites are going to be able to open, or when people are just going to feel safe to start to engage with one another. So I think the need to continue to invest in these local services that are trusted and have access is going to continue to be so critical.
Okay, thank you, Lucy. Well, let me save best for last. No, that's fine. Jane, not really, but Jane, just wanted to say that, Jane Gilbert has been just an enormous asset, I think, to Kentucky teachers, but also to BMA, in explaining how a part of MA that's not well understood is this program called the employer group waiver plans. So Jane's been a leader in this, for Kentucky teachers, all being enrolled in Medicare Advantage. This is an area that continues to grow. We've seen increased enrollment from local and state retirees, as well as from teachers as well. So people who on union plans as well, who have been given health benefits as retirees. But of course, finances aren't so easy. So Jane, talk to us about what this has meant. Since you've been using MA plans since 2007, I think you once told me it was almost $2 billion in long-term liability savings for the retiree system for teachers in Kentucky. So tell us more about how MA has helped to maintain that commitment to retirees, and what your retirees tell you about Medicare Advantage.
Thank you, Congresswoman Allyson Schwartz. Thank you very much. And thank you to the BMA. And Allyson, I can't thank you enough for the last 6 years and what you meant to the Better Medicare Alliance. Always glad to tell my story, and thank you for letting me do that. I have the pleasure and opportunity of serving 37,000 retired teachers on Medicare. As you mentioned, Allyson, we've had a Medicare Advantage plan since January of 2007. So 15 years, that's a couple of lifetimes in the insurance industry itself. What we've proven is that Medicare Advantage is very stable and very financially feasible. What you heard me refer to before is we've been able to shave about $1.9 billion off our other post-employment benefits liability. So that's an actuarial liability that's predicted out over 23 years. And so because of the move to Medicare Advantage and the continual ability to keep our premiums down, we've been able to now bring our medical insurance fund to a funding level of 61%. And what that means is we now have 61% of the assets needed to pay for the cost of care for our retired teachers over the next 23 years. And Medicare Advantage and Medicare Part D and a solution known as shared responsibility, all three have played a very important part in making sure that we as fiduciaries bring stability to our retired teachers. And it's not just a actuarial savings. It's not just a 23-year savings. It is a year-over-year savings in that regard. So our premium for our MAPD, our Medicare Advantage prescription drug plan, our premium is now 20 years later, it's about $30 shy of what it was 20 years ago. And we have not decreased any of our benefits in any material way. In fact, we've added supplemental benefits. And so teachers' retirement system, being an EGWIP, employer group waiver plan, as you indicated, having 37,000, we feel it's our fiduciary responsibility to find and to prove and to show how Medicare Advantage is working. You have to find a Medicare Advantage carrier with 4 stars or better. You just simply have to do that. You have to find a Medicare Advantage carrier that has the most accurate risk adjustment factors possible. What that does is allow your carrier to maximize their revenues from CMS. Once your carrier maximizes revenues from CMS, then folks like me will help beat that premium downward to the lowest possible that it can be, so that we can in turn also do some of the good things that Medicare Advantage does. So through United Healthcare, our partner, we do 6,000 to 7,000 house calls per year. We allow thousands of referrals to clinical management programs and case management programs. All of that, as Dr. Fernandopulle mentioned, is not existent in original Medicare, non-existent in original Medicare. Just a little bragging on our retired teachers in regards to telehealth and virtual visits here in Kentucky. So prior to COVID, we were at less than 1% utilization of telehealth. Even though we offered it through AMWell and Doctor on Demand, we were at less than 1%. And through United Healthcare's help, in April, that jumped up to 55% utilization. In May, that was still up 27%. And since then, we've been looking about a 9 to 12% utilization of telehealth, which is just great, especially in light of the continued COVID and, the 7 or 8 inches of snow that we have here in Frankfort, Kentucky, which is a little unusual as well. In turn, with the savings, we also see improved health outcomes through our partner with United. In 2019, 87% of women had a breast cancer screening. 78% of our retirees had colon cancer screening. 53% obtained their Medicare annual wellness visits. In 2020, we closed gaps in care 7,856 times for those retirees in our diabetes population. We had 734 home screening kits. We had 1,880 inpatient cases supported by transitional care.
Wow.
I'll stop there. I could keep going, but I'll stop there for now and do see this as our fiduciary responsibility to bring the best possible coverage to the retired teachers at the best value. And as Dr. Fernandopulle said, Medicare Advantage itself is probably one of the best examples of value-based purchasing that there is out there. And so you hear a lot of folks refer to value-based purchasing, this or that, but clearly this is one example of a public-private partnership that is working. Thank you.
Well said. Well said. I want to get to questions right now, but keep in mind if we have time to talk about what we think might be barriers we're overcome. We're talking to staff who advises members of Congress. I know from my time in Congress, we really relied on my staff to bring issues to me that could be addressed, whether it's being allowing audio only, data collected from audio only for risk adjustment, or it's the rebate rule we work so closely on Jane, it's still an issue out there. There are issues that come up from time to time where sometimes we say we don't need anything fixed, we're fine, but we're always looking for ways to either address problems that exist out there or that have occurred, such as the one about use of telehealth and audio only, that we need to have addressed, that we do call on policymakers. So let's get some questions, but maybe we can come back to any thoughts that any of the three of you have about changes that we could make to strengthen Medicare Advantage as we go forward. But I think all of you have made a wonderful case of making this real. All those numbers and charts that Deborah showed, really making it real for our audience. So I think we're closing in on not too much time, but let's see how many questions we could get to. Deborah, do you have some good questions for us?
Hi, Congresswoman. Yes, we do. So one of the questions that came through is how are Medicare Advantage plans addressing health equity for beneficiaries of color and Latinx communities and other minority groups?
Okay, I think we heard a little bit of this during this, but Dr. Fernandopulle, you want to stop there? Because you said you have a number of minorities and have addressed disparities without saying those words. Maybe you want to offer that a beginning conversation there?
Yeah, I mean, so this is why risk adjustment is so important to Medicare Advantage. It allows us to be able to go in and serve low income and minority communities and adequately get paid for doing it, because unfortunately, as you all know, the burden of disease among minority communities is higher, and those are have a long discussion on why that is, but in order to serve them, we actually need to get paid more, and the risk adjustment by and large works. By the way, you asked why it is that what could be changed. I think actually using socioeconomics as one of the factors in risk adjustment is something that I think we all need to do. Given the same patient with the same disease burden, we know that the folks who have got lower socioeconomics and less resources have a harder time controlling it and need more help. And right now there's no actually compensation for it, right? It's purely clinical. So again, I think that's something we do. So we and other people under Medicare Advantage actually preferentially go after low income and minority communities. And we're able to actually dramatically improve their health. That we've done some studies which are really interesting, where when people come into us, if you're Black or Hispanic versus white or Asian, you have worse outcomes. And those outcomes that disparity almost goes away once you actually give people the right care. Right. And again, I think using Medicare Advantage. So I think the program is really built for that. I think if you cite some stats, this program almost disproportionately serves those sorts of communities. It's a no-brainer, by the way. If you're a low-income American senior, you can pay these huge cost shares in original Medicare, or for zero premium in most places, you can get all of these benefits without a lot of. So I think in some ways it's a no-brainer, particularly for low-income people, to go join a Medicare Advantage plan.
Right. Others want to join in on this, or we can go into the next question. Nate will jump right in, but appreciate that. And I will echo what you said just by saying that BMA is very interested in this issue of achieving health equity and doing so by getting the right care to the right people, and really impressed by so many of our providers who are moving into opening centers in poor minority communities, particularly because the communities that need to have the trust built and to be local and to be able to address a variety of needs outside the hospital in particular. And that's really been a long time coming, and exciting to see that kind of work. Deborah, you have another question for us?
Yes, thank you. So in Congresswoman Schwartz, this one might be best answered by you, but everybody else, of course, please feel free to jump in. Can we expand just a little bit more on how the quality measures in the star rating system are developed and what that process looks like?
Oh, yes. Well, I can, a quick overview on that. I happen to serve on a technical expert panel. It's called a TEP on star ratings. It's been going on for a year and a half almost. And I can tell you that there is a lot of work goes into making decisions about what the quality measurements are. They're constantly changed. They are constantly moving. It's a very dynamic process. It's not like they set a measurements and then you're done. You have to keep improving to keep your star ratings what it is. And they do change, and they are differently weighted. So they're a mix of clinical outcomes as well as sort of more process outcomes. It goes to how many women got mammograms, how many got screenings of the kinds, how many get flu vaccines. I'm sure they're going to build in COVID at some point on those vaccines. How much you ask about fall prevention, and as well as where people stand in terms of their diabetes and that sort of thing. There also are consumer experience measurements. Some of those we have some conversations about whether they're the most valuable in terms of what consumers really care about today or offered in the right way. But it's an ongoing process. There's some quasi public groups that actually help do the technical work on this, but it's constantly changing. But what I will end by just saying that it's been an enormously successful program. The Medicare Advantage gets a composite score of all of these things, and they are public. Whether you get a 4 or 5 star ratings. Of course, it's on a curve, so the number of 4 or 5 star plans also keeps moving. They're harder to achieve, but we've moved from about 26% of beneficiaries in high star plans, 4 or 5 star plans, about 10 years ago when it just started, and now we're seeing 77% of enrollees in Medicare Advantage are in 4 and 5 star plans. The idea that that plans and providers work very hard to achieve these goals. And then the quality bonus payments, as Deborah pointed out, have to be used directly to benefit beneficiaries. It can't go into profits. It can't go into administration. It has to go into direct benefits to beneficiaries, hence lower cost sharing for beneficiaries, more care management, but enhanced care delivery. So it's really just been enormously successful, both in terms of achieving goals set by the government, as well as in making sure that beneficiaries benefit from some of those cost savings and improved health that comes from it. So that's a shorthand. So I talk fast to try and fit in more. Let's see if we can get another one.
Thanks, Congresswoman. Actually, at this point, I think we are all set in terms of the question and answer period, and we're actually at the top of the hour as well.
We are. So I will say this. I think we've gotten quite a bit in, and I really appreciate very much our 3 wonderful panelists for participating and sharing your enthusiasm and experience and expertise around Medicare Advantage. We will keep asking you to do that kind of thing. And I will just say to those in the audience, we're going to sign you up for our policy alerts. We put out alerts whenever there's a new regulation or congressional action, and you can read them if you're interested and set them aside if you'd like. But know that we are a resource, and that we are happy to answer any questions you might have about Medicare Advantage or Medicare going forward. But to know that on behalf of the 26 million beneficiaries and growing, many of whom, as pointed out, are low and modest income, a higher percentage of minorities, and people with chronic conditions. So I think we're doing some pretty remarkable. Well, we work on the policy. All the people you hear from are doing the remarkable work of Medicare Advantage. So be in touch with us and ask us any questions. Deborah, thank you for your presentation. And I want to wish the very best to all the congressional staff, both Republicans and Democrats who have joined us. Good luck in working together and in working together in a bipartisan way to support Medicare Advantage going forward in 2021. Thank you.